Good evening, everybody. Thank you very much for joining us to this last PCR Tricuspid Focus Group webinar of the year, live from Paris. My name is Fabien Prat. I am an interventional cardiologist from Switzerland. Today's topic is a very innovative, very interesting one about intracardiac echocardiography for tricuspid intervention. So a very exciting topic as well, I think, for everybody. So thank you for being with us. The objective of today's webinar will be to make you familiar with this new technology. Maybe some of you have never seen before, which is a very innovative one. Also to discuss some of the limitations of intracardiac echocardiography and to discuss further opportunities for the future of this imaging to help tricuspid intervention, which are quite a complicated intervention. I am surrounded by a stellar faculty for doing this. So on my right, I have Stefan von Badeleben from Mainz, interventional cardiologist. Thank you very much, Stefan, for joining us live from Paris. And on my left, I have Isabelle Körber from Cologne. She's interventional cardiologist and imaging specialist, so she has both specialties and will help us to understand a little bit better what is the role of intracardiac echocardiography for tricuspid procedure. And we have also Becky Hahn from New York, Columbia. Hi, Becky. Thank you very much for joining us online from the US. And Scott Lim from the University of Virginia. Hi, Scott, and thank you for joining us. So, Stefan, we will be, of course, answering questions from the online audience as well and give priority to this. How can we do this, Stefan?
So it's very easy. We will use Slido, and you have all the information on the web and while registering. And it's a great pleasure that we already have European participants, and we also have some participants from Northern Africa. So warm welcome to all these participants. And they know how to integrate and use the chat function here in order to bring questions live into this webinar, Fabien and Isabelle.
Thank you very much, Stefan. So ask your question, be interactive. We will, at any time, Stefan will intervene and give priority to your question. First, Stefan, I would like to start with introducing the technology. Maybe some of the people looking at this program does not know everything about the technology. So I will ask you to bring in a very small lecture. What are the technology which are available? Some of them are approved in the US, others in Europe. So you will give us some insight on this. And then we will go for a live demonstration on the catheter. So please, Stefan.
Thank you, Fabien. And we'll run into the ICE in interventions. And this will be a presentation of the available technologies, not only in the US, but also in Europe. And we start off with the VeriSight system. The VeriSight Pro ICE system poses a typical system to steer intracardiac echocardiography. As you can see, we have a working length of about 90 centimeters. It's a very thin catheter. And Fabien, we will see this in a minute with a live demonstration and hands-on on these catheters. What is unique is that we can change the flexion of this catheter, not only in antegrade and retrograde flexion, but also in the right and left flexion. And we can engage the clutch in this catheter. In order to see this slide deck, and perhaps we can bring the slides back up, we can appreciate that we have a difference in the arrangement of the discrete elements. So looking back into 2D ICE, which is available for 2.5 decades and was mainly used in electrophysiology interventions, we see that on the right-hand side, we now have a much larger array, which is an X-matrix array, and you can see that the number of elements increased 14-fold. So this is the important part of quality and the capability also not only to rotate like an old multiplanar TOE probe, but also to go ahead and have a sort of pyramid that we can freely rotate in space, and we can first appreciate all landmarks of the tricuspid valve, for instance, and on the same time control both levels in a 90 by 90 degree view, which is unique and has developed in the last 5 years. If we compare this to something that we are used to, and this is the TOE probe, which is since 2007 three-dimensional, you can see that the number of elements still is different. So while the number of elements according to the tube shaft in TOE is the same than 90 degrees to it, we can see that on an ice catheter, because this is only a 9 French device, so only 3 millimeters wide, of course we have more elements in the longitudinal direction than in the transverse direction. And this is important when we image. Just to have a look at some image examples, Fabien, this is imaging with a resolution, spatial and temporal resolution of 56 Hertz. So I think it compares nicely to what we know from TOE. You can appreciate that very often there is a slight angulation to the basic zero plane, and this is typically not 90 degrees, but 45 or 60 degrees. And in order to use these oblique cuts, we recruit more elements for image quality, and this is important to know, and one of the shortcomings, of course, of these very small shafts. Here as an example, and we see another example later from the US, you can see a tear intervention, and you can highly appreciate that we're able to see the leaflets on in a very, very good fashion, and we have almost 30 volumes per second in these MPR analysis. Coming to additional technologies, and Scott Lim will later show a live example of this technology, which is also not yet CE marked. This is the new Vision device, which is unique as you can flex the system in order to look at different parts of the heart, and you can then rotate the imaging head inside the catheter without giving up the flexion. And I show you this here in a fluoroscopy view, and you can appreciate that the image camera is rotating inside the catheter, not giving up the flexion, so not having to move the catheter around, but you stay in one place. The last system now is also CE mark. It is available in Europe. This is the Acunef and the new Acunef Lumos system, which I'll show you shortly. It's pretty much the same. It's a little thicker catheter, and we'll appreciate this in the hands-on. It's 12.5 French, also a working length of 90 centimeters. You can see we have up to 60 volumes per second. It uses 2D, it uses multiplanar reconstruction, and also color Doppler. So all our color Doppler and our Doppler capabilities, including pulsed wave Doppler and continuous Doppler, are available. You can see that the image quality over time increases. We have all the landmarks here on the tricuspid valve, aorta anterior, septal leaflet down, anterior leaflet to the 10 o'clock region, and to the 5 o'clock region, the posterior leaflet. And you can see that we can use MPR live as we do it with the CT images during our procedures. And this is a view into the future. It's the new Acunef Lumos system, where we'll also see one sample in the slide deck. And it uses some artificial intelligence in order to follow catheters, plastic and metal devices. And I think we will see the benefit of it. And I think now we should go on with some hands-on experience, Fabien and Isabelle.
Yes, thank you very much, Stefan. So, very good summary of what is available in terms of technology. And we have here one of these catheters here in the studio. So what you can see here, and let's focus first on the handle of this catheter. And what you can see first is here a connector. This connector will be then, this part has to be sterile on your table, and the connector will be linked to the echo machine. And then you have an handle here, as you can see, with two levels of steerability. So the first knob and the second knob are done for steerability, and you can move the catheter, flex the catheter towards anterior, like A, and posterior, and toward lateral, left and right, or lateral, as you prefer to name it. And you have also a locking knob that you see on the handle as well. So this one is the Acunef catheter. That's the previous version of the Lumos Stefan just mentioned, but that's the version that is currently available in Europe. It's actually the only ICE catheter currently available in Europe with CE mark. So you can see the catheter is a 12.5 French catheter, so you will typically need 30.5 or 14 French sheaths to introduce this through the venous access. And then what I will show you, and we will then be able to compare also with Philips catheter, Stefan will show you in a minute, We will show you a little bit the steerability of this catheter. So Isabel is the hand of Isabel. On the right side is vena cava inferior, and on the left side you see actually what is a plane of the tricuspid valve. And then you will see that if I move this steerable catheter and moving the knob toward anterior will bring me toward the tricuspid valve, and will allow me to image the tricuspid valve in an home view. So that's exactly the position you will adopt in the right atrium, coming from the vena cava inferior, a little bit of anteflexion, and then you will move your catheter up and down, or be able to turn it as well to adjust your plane. What the catheter can do as well, you can retroflex the catheter. I think you see that. We go toward posterior, toward the wall of the right atrium. And then in this position, you will be able to image the septum. And then in addition, you can combine all these movements. And of course, what you are able to do also is to go lateral or left. You can see this movement here, or right, up, here towards the tricuspid plane, to be able to adjust your imaging. So a very high level of steerability and a lot of possibility to have the best image. So Stéphane, maybe we can come to your catheter and see some of the differences. This one is a Philips catheter, which is not CE mark yet.
Yes, Fabien, and we just want to highlight that this catheter is very thin. So what we have seen over there is a 12.5 French catheter. So like the flush port, we have the clutch control here on the top. So the imaging is directed actually to this control. And then we have two steering capabilities, flexing capabilities. One is posterior or anterior flexion. And the other one, this is unique, is a right to left flexion. And what we can do now, if we take a look at the whole catheter now with the camera, is that, of course, I can come up from the inferior caval vein. And again, Fabien, with his hand, is marking the tricuspid valve as a marker. We can now anteflex in order to see and direct exactly at the tricuspid valve here, anterior. I do an anterior flex here. If I come from the jugular vein, I would do a retroflex like this. And if I have this anteflex and my caval vein is very posterior, Fabien, then we can elevate this catheter by doing a rightward movement. So this is like the secondary flex, for instance, at the EVOC valve. So we have a possibility to elevate ourselves in very dilated atria. The second method that Becky will show later in her talk is to do an inversion of the catheter. So I turn the catheter away, and instead of flexing anterior in a very large situation where the hand of Fabien moves away, I can invert the catheter and do a massive retroflexion, which is almost 360 degrees. And by moving up, I have the possibility to actually be much closer at the valve, and also to move now in the left direction up towards the valve if this is a very dilated right heart. So unique new possibilities actually to steer. And then you engage your clutch, and the catheter stays in this position. I can lay it down on the table, and you can continue with your intervention. So I think that's also a very important thing to note.
That's very impressive, Stéphane. So actually to do this, you will engage the right atrium with the beam looking away from the tricuspid valve, and then use a complete retroflexion of the catheter, which this catheter is able to achieve, to have the beam directed towards the tricuspid valve. And that gives you really an angle that you cannot achieve otherwise.
Exactly.
So very nice demonstration. Thank you very much, Stéphane. So now we show you a little bit the possibilities of this catheter, and we will go to the main indication for eyes. So Isabel will present us very quickly what are the indications and in which situation you should consider using eyes, and then we will have a discussion all together. Isabel.
Yeah, perfect. Thank you very much, Fabien. So a few words on the main indications for eyes. Of course, a very good indication for eyes is if we have a contraindication for transesophageal echocardiography. There might be absolute contraindications, like, for example, example, a perforated viscous, also different esophageal pathologies like strictures or prior trauma, tumors, also scleroderma. Of course, there might be a contraindication if the patient has active upper GI bleeding, that's quite intuitive, and also if there has been recent upper GI surgery or esophagectomy. Relative contraindications might be related to the cervical region if there is joint disease or, for example, cervical arthritis. Also radiation to the chest, different kinds of hernia, and also GI surgery or GI bleedings or esophagitis. Also sometimes thoracoabdominal aneurysm pose a risk for insertion of the TEE probe, or Barrett's esophagus or dysphagia, or different kinds of coagulopathies. Sites of potential injury for the TEOE probe are oral, of course. We can have dental or lip trauma. We can also have oropharyngeal or laryngeal, very difficult words, laryngeal trauma. And of course, we can have bleeding, laceration, and perforation, also esophageal or gastric lesions. But not only if there are contraindications for TOE, we might have a benefit of ICE, but also, especially if we want to image the tricuspid valve, it's sometimes very hard to do or challenging because the tricuspid leaflets are way thinner than, for example, the mitral valve leaflets, and also they have varying coaptation lines. Also, anatomically, the tricuspid valve is the most anterior part of our four valves, and it's further away from the esophagus or the TEE probe. And on fast imaging, it's not possible from a mid-esophageal view, and sometimes this can be also challenging or more complicated in a horizontal hard axis. These are a few examples for very challenging imaging scenarios, especially for the tricuspid valve. There might be achalasia, there might be very huge left atria that cause shadowing on the tricuspid valve. Also, there might be very lipomatous septum that also cause acoustic shadowing on the tricuspid valve, especially sometimes on the anterior septal portion. And sometimes there are also very poor transgastric views, for example, for different reasons, or there are leads implanted or other devices, for example, left-sided prosthesis that make it sometimes very hard to especially image the leaflets of the tricuspid valve, as it's shown here on the right-hand side, about the benefits and the limitations compared for TOE and also ICE. If we look at the access side, of course, this poses risk for both methods. With the TOE, we have a GI trauma risk, and with the ICE, we have a vascular bleeding risk that's very small, but it's still there. If we think about patient care, I think that this is a big pro for the ICE probe, because here anesthesia is not necessarily needed in the patient. If we think about the NPR orthogonal field, the TOE has a very good NPR field, and for the ICE, it has to be said it has a limited NPR resolution. A big point is, of course, still the costs of the probes. For TOE, the probe can be reused, and mostly for ICE, that's a con. This has a very high cost of single-use catheters. Anatomic-wise, I already said, with the TOE probe, we are quite distant to the tricuspid valve and also the annular plane. For the ICE, that's definitely a pro because we're right in the right atrium. It's very close to the tricuspid valve, and it makes visualization of the leaflets very nicely. Far-field imaging is a pro for the TOE because here it's superior for far-field structures, and with ICE, we have a limited far-field imaging. So, to summarize, contraindications for a TOE, of course, then here is a benefit for the ICE probe. And with growing numbers of the tricuspid procedures, sometimes tricuspid valve imaging is quite challenging, and here there might be a benefit for ICE, especially if the visualization of the leaflet is poor.
Thank you very much, Isabel. And I would directly go into your talk and ask you, so you talked about the contraindication, but what would be your best indication from a morphology or valve standpoint for ICE? So when would you prefer ICE, even if there were no contraindications for TOE?
Yeah, I think it's very important that the patient has not so, with TOE, if we have perfect imaging for the tricuspid valve, then there's no need, of course, for an ICE probe. But if there is, for example, a very poor transgastric view, as I've already said, then it can be a very good point to use maybe a TOE simultaneously to an ICE probe.
Okay. We also want to engage our US colleagues that are online. And Becky, I would give the next question to you. Do you use ICE as an adjunct technology, or do you have an exclusive use for ICE? What's your experience in Columbia?
Oh, that's a great question, Stefan. And we like to use it as an adjunctive tool. The field of view for the transesophageal probe is so good that it can be useful, for instance, from the transgastric view, where we're very close to the tricuspid valve and gives us a wide field of view. It's the only two-dimensional imaging, which then gives us high spatial and temporal resolution, that allows us to see all three leaflets and therefore orient devices such as the TEER devices. But obviously we can't, it's very hard to get that full field of view with an ICE probe. And so we like to use the two together, using the strengths of each of them to perform the procedure more precisely and typically with less time. So the procedures go a little bit quicker. We're not moving the probe around as much because we're able to use the ICE in what would be a standard almost mid-esophageal view for a TE probe, and then maintain the transgastric views at all time for orientation.
Thank you very much. Important points to recognize. Also, I think in the course of the learning curve, it is very good to start as an adjunct technology, and perhaps later, as we may move away from general anesthesia, it may also become an exclusive tool, actually, for certain easier or routine use interventions. Scott, also to take note of your high experience with 3 different ICE devices, what is your thought on the use of a steerable sheath versus using no sheaths? We've seen that we have devices between 9 French, 12.5 French. Some are more stable, some are a little bit more floppy. What would you use? Would you always use the catheter in itself, or would you also sometimes use a steerable sheath? What's your experience so far, Scott?
I think it depends on which device I'm using. Early in our experience, when we were using the Siemens 3D ICE probe, the internal mechanisms weren't very robust, and the articulation point was farther away from the tip of the catheter. So I oftentimes felt using, as you brought up, a external steerable sheath to help articulate it, to move it closer to the object of interest, which back then oftentimes it was tricuspid annular interventions. Now with both the Philips and with the Biosense Webster's New Vision system, I think the internal articulation mechanisms are much more robust. They're also closer to the tip, and I find that you can depend just on its own mechanisms alone and not have to use an external sheath. You know, the other piece I just want to put in there, my 2 cents, I agree with Becky, particularly for a lot of things. We use ICE as adjunctive to TEE or TOE, but more recently, as our skills have gotten better, as we've gotten better on the learning curve, we have, and I'll show you cases now that we're able to do where we use ICE as our predominant imaging technology to guide us through the cases. And I think that gives a lot of possibilities. It opens up how we could do cases in the future without TE, without anesthesia, and without endotracheal intubation, and make it much more efficient procedures.
Excellent points. I would hand over to
I think that's a very important point, this with the additional sheath, and you know, it increases stability and enhance a little bit your steerability. So that's something, when you use ICE, that's something that you need to consider very fast in your experience to have a more stable catheter position, but also to have more steerability. So Stefan, can you give us a little bit the name of the sheaths you can use in that situation? What are the options there?
There are different large sheaths actually that have steerable capabilities. For instance, there's the Occlutech and the Oscor sheaths that work very well. They have a shorter working length, so you can come out. These ICE catheters typically have 80 to 90 centimeters working length, so you're able to leave the steerable sheath, and Oscor and Occlutech are available in 10, 12, and 14 French sizes, which is important for all those devices. So with the 14 French, you can do the Siemens, and with the smaller ones, you can do the New Vision or the VeriSight probe then.
And maybe one question to you, Isabelle. When you are using ICE, which is the axis you use usually? You know, is it the femoral, the right, the left, the jugular?
Yeah.
What
I mean, we have actually different options. We can use the jugular. We can, of course, use the femoral veins. And, of course, there are 2 different options. We can use the contra and also the ipsilateral vein. To be honest, I've always done it on the contralateral side. I don't know about you guys. Have you mostly done it like also femoral, or...?
Yes, well, I used it mostly femoral, contralateral,
Yeah.
and I typically place the ICE probe first and then I use the implant device, which typically has a much larger sheath size. So it's easier to get the ice probe in first, also to have the visual control on the right atrium, and then to enter with the interventional sheath on the other side. So typically I do this contralateral on the left groin, the ice access, and on the right-hand side, I do the intervention side. But for certain devices, it may be different. So we have, of course, jugular approaches with the Lux valve, where you, again, will use the femoral side. But there have been cases, especially for smaller interventions or TEER, to use actually the jugular access, especially if you only have 10 French, then it's very nice to use a jugular access.
I mean, the French size is probably not so much of a problem because, of course, we are on the venous side. It's not an over-the-wire technology, so it's something you need to introduce into the groin. So I would advise to use a long sheath, actually, so that you are already above the bifurcation and can introduce more easily the catheter. Scott, do you have experience with jugular imaging?
Yeah, we have tried doing jugular imaging. I think everything is flip-flopped when you're coming from above, and so I tend to like to keep it as down from the femoral. And I agree with your statement. When you put it contralateral, say on the left femoral, you really need a slightly longer sheath just to get you out of the pelvis.
So these are a bit maybe technical consideration, but I think that's very important to mention, to have also a very practical approach, because that's the problem you will face very quickly when you start with ice imaging. Stefan, I think we go to a case now.
Yeah, I think we move on to Becky Hahn, and with a presentation of a patient case undergoing tricuspid edge-to-edge repair under Philips ice. And Becky, we like to see your case. I think it's the most used scenario on the tricuspid valve so far, and so it's highly important. Becky, please give us your thoughts.
Yeah. Thank you so much. If you could have the slides up. Yeah, so you'll see this device being used in this particular case, as has already been stated. Depending on the imaging requirements of your particular device, you may or may not, require extensive additional modalities. So frequently with TTVRs, we only need one, even if it's a 1 millimeter view. But this will be a case where it's very important to have the two adjunctive modalities. So this is a 66-year-old man, past medical history, as you can see here, of hypertension, hyperlipidemia, a viral myocarditis with heart failure with reduced ejection fraction, which improved on the medications that you see shown here. In addition, the patient had hyperthyroidism and hyperthyroid storm 10 years ago, and in that setting had uncontrolled atrial fibrillation requiring AV node ablation and a pacemaker placed. So 10-year-old pacemaker in place. Tricuspid regurgitation was noted since the pacemaker was placed, indicating that there may be an involvement of the pacer as an etiology for the TR and other comorbidities, as you see here. He presented to us with easy fatigability, a shortness of breath on exertion. He could only do one flight of stairs. At times, he was waking up at night short of breath with leg edema at the end of the day. You can see that he's 100% pacemaker dependent. Next slide. Sorry, I think I can control them. So this is the baseline transthoracic in red, and the rest of the images are the transesophageal echo. The transthoracic clearly shows the dilated atria, the dilated annulus, and then the pacemaker. The pacer, we believed, based on three-dimensional reconstruction, was indeed impinging on the leaflets posteriorly in the posterior septal commissure, but also in preventing leaflet closure. The 3D vena contracta area suggested that this was massive amounts of tricuspid regurgitation, which you can see also on the esophageal imaging. The disturbing thing was that there was a lot of acoustic shadowing from the pacemaker, you can see on the bottom imaging, as well as a very horizontal heart. In the setting of a horizontal heart, we will frequently depend on other imaging planes, but you can see even from the transgastric views, we were having difficulty imaging leaflets and the regurgitant orifice area. Next slide. Oh, sorry. I can do that. So I'm going to go back one, sorry, and just show you the the Verisight probe that we ended up using. So this is going to be use of the Verisight in the setting of difficult TEE imaging. You've already seen what the Verisight looks like. Remember that it is lateral and axial flexion. This is what it is capable of as far as lateral flexion, but again, as Stefan has shown you, this is a particular patient with massive atrial size, and therefore we needed to get closer to the valve. We inverted 180 degrees from the home view and then retroflex in order to get what's called the inverted home view. So on the next slide, you'll see the standard home view and then the far field imaging that would be required for this particular large right atrium. And therefore, we inverted the ICE probe, which you can see on the fluoroscopic image. And in that setting, we now have inverted our image. So from a posterior anterior septal lateral, we now have the reverse, the anterior posterior lateral septal. But our imaging plane is obviously significantly closer, allowing us greater visibility of the device when it's introduced. And so using three-dimensional imaging on the TEE probe, this is from mid-esophageal views, we were able to see not only the pacemaker, but the ICE probe. So here's the pacemaker. We had to make sure that the device came on one side of both the ICE probe and the pacemaker, and we did this using live three-dimensional imaging. So the ICE probe is now in its inverted position. The pacemaker is toward the septal side, and now the device is being directed down toward the tricuspid annulus. You can see that the orientation of the device can be achieved from a transgastric view, but the mid-esophageal views are very difficult to see leaflets and device arms. So again, from fluoroscopic image, we will park the probe in the transgastric view in order to maintain our view, our large field of view for device positioning. This is the TEER device, the ICE probe, and this was the CS lead. So on the next slide, you'll see the ICE imaging for the grasping of the leaflets. So this is a Pascal device. We're seeing here biplane imaging, which is a three-dimensional function. We can see all components of the device. We are now laying down just the septal leaflet first, and then on the bottom imaging, you can see we are then moving over and laying down the anterior leaflet grasp. In the final, you'll see the device closure to the far right, and of course, a significant reduction in the amount of regurgitation. So the final TOE imaging shown on the far left with the three-dimensional glass view to show you the significant reduction in tricuspid regurgitation down to trace or very, very mild. And then we have 1 year follow-up on this patient showing again durability of the device with very mild regurgitation, again, posterior to the ACE device. The patient had a significant reduction by 60% of his diuretic requirement. He's now able to climb 3 flights of stairs without shortness of breath and has had no further heart failure hospitalizations.
So thank you very much, Becky. This was a fantastic case, in my opinion. If I might pose one question, how much would you say that this TR was lead-induced only because you went on with a TEER strategy and we saw so great pictures of the lead in the septal commissure?
Yeah, what we try to make sure is that, so the residual regurgitation that we left might have been in part related to some restriction of the leaflet. But if there's a lot of regurgitation anterior or far from the pacemaker lead, then we feel that we can probably reduce the tricuspid regurgitation. In this case, we took it to an optimal result, which was only trace to mild regurgitation. But sometimes you'll live with some regurgitation where the pacemaker is impinging on the leaflets in order to just reduce the amount to at least moderate. This case ended up, having a very good result. But even in the TRILUMINATE trial, we saw that there was an increase in the number of pacemaker patients that were allowed into the randomized portion of the trial as we learned that we could actually reduce the regurgitation even with impingement.
Thank you very much, Becky. Great case, great explanation. Stefan, we have a question from the audience.
Yeah, it's a truly global audience, I must say. So we not only have viewers and spectators here from Europe, Eastern Europe, Northern Africa, but also Asia. And to remind us that we should also highlight the basics, there's one question by Rehal on how to insert practically the ICE probe. Do you use a guide? What do you use to get to the position to get to the right atrium? So this is one of the online questions.
Scott, do you want to answer this?
Sure, because I think it's a good one. And a lot of it depends on where your access point is for the ice. Most of us, as you've heard, are putting it transfemorally from the contralateral leg. So if the delivery system is for whatever intervention valve you're doing is coming from the right femoral, we're going to put the ice in from the left femoral vein. But to be able to navigate this, since these are not over-the-wire systems, I'll first take a bit of a longer sheath, just 30, 35 centimeters long, that we can then insert up to the inferior vena cava. Then through that, I'll go ahead and run the ice catheter. And from then on, it's a fairly straight shot up to the right atrium.
I think you are right, Scott. I think it's not so difficult to achieve a good catheter position. Of course, you will have, depending on the anatomy, to make small adjustments, and the catheter allow you to do this. But actually, by bringing the catheter in the middle of the right atrium and then looking at the septum by retroflexion and anteflexion toward the tricuspid valve, you will be able, with adjustment that are difficult to predict, actually, you will be able to have a very good image. There are some challenging, Isabel, that are linked to transcatheter edge-to-edge repair. What is very important to have and to look at, when you do ICE in a transcatheter edge-to-edge repair case?
I mean, actually, especially for TEER, I think ICE is of great benefit, because in TEER, we need to have a very, very good, if not perfect, visualization of both leaflets simultaneously. And here, sometimes with the TOE probe, as I've said before, it can be really challenging. What's really important and essential is that we need to use also biplane images and also 3D volumes, of course. And what still can be a little challenging, in my opinion, is that the resolution of the MPR and also the 3D volumes might not yet be perfect with the ICE probe. But overall, especially in TEER, I think ICE can be really beneficial because of the very good visualization of the leaflets.
I think the revolution, Stefan, you will agree, is the 3D with this ICE catheter. And before 3D, we were not really able to do edge-to-edge repair, at least because we were not able to see the other dimension and to make sure we are looking at the right plane to ensure a perfect grasping. What can you say about the assessment of the result? How is it looking on ICE?
It's very important. Two points. We always use the cranial to caudal direction, so anterior, posterior, with the best resolution. And this is the reason that 2D ICE has not been adopted. I think 3D ICE has the advantage to have an additional plane, and the grasping area most often in the tricuspid valve is offset by 60 to 90 degrees to this first plane. The second point is, I think, very important. As we are in a very close field and we have no artifacts in between, no septum in between, especially the color Doppler of these ICE probes is extremely sensitive. So I would, if you also now see the next examples, don't be overwhelmed by the color, and don't be overwhelmed by the color after you treat the valve. And I think Becky has already shown it a little bit on the follow-up after 1 year in TTE and also in TOE. It looked much more trace than mild to moderate, while on the ICE probe it looked rather mild to moderate. And we should be very cautious in evaluating the severity by ICE only. I think that's a very important message to the audience.
I mean, the scale is also different on ICE, and what you see on the screen is much bigger than on TOE. So I think some good result can look quite worse on ICE, but more important is the strategy and to have a good result afterwards on TTE as well. So I think a bit of cautious in the interpretation of the result as well is needed. So Stefan, I would like to move now to another strategy for treating the tricuspid valve when you use ICE as well, with I think the last version of the Siemens catheter, which is not CE marked now, but offer a better resolution. So Stefan, please.
Absolutely, Fabien. And just to have an impression of the situation that we had in the last 3 years, this is the also new Aconav catheter. with the ST2000 system. And just an example of multiplanar reconstruction and grasping and leaflet insertion here in a tear case first, and then in the second slide here, the possibility to depict, as we see in EVOC case, where we also engage with 9 anchors, the tricuspid valve, and you can nicely see how the leaflets are lying on the exposed 90-degree flipped anchors. You see the flipping of the anchors in the lower image, and the right-hand side you see the exposure, and you see it's a perfect case where even with the high sensitivity in color, you see no paravalvular leak in this EVOC case in tricuspid.
But that was the old version.
That was the old version, and you see it by the temporal resolution. So if you look closely, you see that we had here 9 to 13 volumes per second in MPR, which is already impressive. But now I show you another case, if once we get the slides back. And this case here is a 74-year-old female that was approved by the German BfArM, which corresponds to FDA, as a single-use catheter because of his prior interventions. He had a TAVR, which also made visualization of the septal leaflet, etc., more complex. It was the first case with the Topaz valve on a pacemaker that was implanted in 2020. You see a severe peripheral artery disease, had a TRI-score of 8, and was also treated with breast cancer, with chemotherapy. So there were multiple interventions that actually went for verse image exams. And if you look at this, this is the combination of a catheter that visualizes by artificial intelligence the continuity here, even in 2D, of pacemaker cables. And you can nicely see that we have here 3 different cables and wires, etc., in the atrium and in the ventricle. And you can now appreciate how sensitive this color is. But I would also point your attention to 68 frames per second in black and white on the left-hand side, and also on 27 frames per second in color Doppler. And this is actually a new innovation stairway that we're seeing next year. And we expect this device to be CE mark. It's just recently been adopted by FDA, actually with the new Lumos and Origin system. And here you can see an interventional possibility, the baseline images of this pacemaker actually inflicting the tricuspid valve, necessitating in this case not a TEER procedure but a replacement procedure. And if we go on in a 3-dimensional visualization, first with the 2-dimensional, and look at the stent frame and also at the color precision, even with this high sensitivity of color, you see there is no PVL. It's a complete elimination of tricuspid regurgitation. And just as the final slides here coming down again from those 70 frames per second going into true multiplanar visualization, we still see 15 volumes per second in all image planes, anatomically correct. And on the left and right hand side, you can beautifully see that we can appreciate the pacemaker that's now been jailed by the stent frame of the replacement in this case. And I think it's an excellent possibility to really rule out paravalvular leak, to really precisely predict, like in CT, now the position of pacemakers and devices. And this would be my case for this additional new technology, Fabien.
So thank you very much, Stefan. Fantastic images with a new technology. Becky and Scott, what are your thoughts on this? So technology that will be obviously available in Europe. Do you think we will be able to do some replacement procedure only with ICE in the future?
Well, I'll show you my next case.
That's the future.
Indeed it is.
Becky, what are your thoughts? I'm not sure you share the same opinion.
Sorry, the TTVRs really require less imaging, intensity, right? So you don't have to necessarily see leaflets going into a device or being grasped. Some devices you just need to make sure anchors are underneath the annulus and the leaflets come on top. It's just less intense imaging. And in some other devices, it's even more limited than that, depending on what your anchoring is for those replacement devices. And so I do think that ICE imaging for less challenging image requirements may be a standalone procedure.
Scott, you agree? I guess.
Absolutely, I agree. Yes.
Stefan, what is your view on this?
Well, we also have online questions, I would say. And
then,
I think
of course.
the online participants are first. So we have a question from Italy, actually, to, I think, also Becky. This is about the discussion we just had. Do you see differences in TR grading by ICE in respect and compared to TOE? Especially with the measurements that change the grading, like, for example, Wiener contractor area in 3D. Can we compare those, or is ICE oversensitive? Becky, what's your view? Is it only the magnification that we see? We're in the near field compared, of course, to TOE, or is there more in it?
Yeah, I think we've tried to look at the vena contracta, and I do think that as Isabel had said, that there are some limitations to the 3D full volume reconstructions and the temporal and spatial resolution that you need to make these kind of assessments. So we still trust our TEE probe a little bit more on doing the 3D vena contracta areas, and as you saw on our case as well, and as you said, Stefan. The color Doppler is just oversensitive. But I do think that the ultrasound companies understand that and are trying to adjust for those while maintaining, what we would perceive as the real, the end result of the TEER device. So it's a hard answer. It's a hard question to answer because we're still investigating. But the ultrasound companies are also changing their algorithms for color Doppler using these probes.
Another strategic question here that is coming from Europe is, what is the practical role and the role change of the echocardiologist during ICE-based tricuspid interventions? Perhaps a question for Isabel.
That's for Isabel.
That's a very politic question. That's why they pose it to me. I think probably, of course, we need to have a change in our vision of the traditional echocardiographer that sits behind with the anesthesia, because maybe we don't need anesthesia anymore then. And so I think... to be not so diplomatic anymore now. No, I'm kidding. I think there needs to be a change in our vision, because I think at least the interventional echocardiographer needs to maintain and adjust our NPR slices and do the NPR at the computer. So he definitely, or she, has to be in place still. There is not only the interventionalist.
I think a very good point, a political one, as we heard. And even though we have more online questions, we, I think, have to move now for time reasons back again to the US. And I'm happy to invite Scott Lim to talk about his patient undergoing a tricuspid intervention under ICE control with the new vision system. Scott, please.
Stefan, thanks. We can have those slides up. And one of the things, this is for a transcatheter tricuspid valve replacement we'll show you. We initially intended to do the case by TOE guidance with ICE adjunctively, although I really, as I just said, I think we're just about there to be able to guide lots of these procedures by ICE only. And ultimately that's what happened in this particular case. So this was a relatively young gentleman who had severe TR complicated by chronic dialysis. And he also had some other coronary disease. Go on to here, let me control the slides. In the very next one, you can see he had fairly reasonable TOE images that I think we could have done quite well with the entirety of this case by TOE, or just using ICE as a adjunctive fashion. And so what we were going to do, he enrolled in a clinical trial. We were going to put in the Trisol valve, which, as you can see, is a bileaflet valve design, relatively low profile, grasps the leaflets with 12 ventricular arms. It is delivered from a transjugular access. And the intention is to do it percutaneously, but this was only our second case that we've done. And so we did it at recommendations of the sponsor by a surgical cut down. And we were just going to use ICE adjunctive to the TOE. But my surgical colleague, once she got in there, the jugular was very fragile, and she was concerned about letting anybody get in or move anything around. So she said no to TOE at that point in time. So we converted over and did the entirety of the case, as you can see here, by 4D ICE. We were using the Biosense Webster's New Vision 4D ICE, and it's a little bit different. I think all of these newer technologies has some slight differences to them. This one has single plane articulation, but it's very stable system because it's the distal tip of it is independently rotatable by the operator. That then allows you to millimeter by millimeter essentially pan through the field, the object of interest. And so here's the images that we were getting there, and you can see we're actually deploying the TriSol device in the RV and then pulling it up underneath the valve. And we're able to change our imaging planes and in a very stable fashion see exactly what we wanted. As Becky had brought up several of these devices, we were able to bring them up underneath and make sure that all the leaflets are coming over on top, as you can see in this image here, is 12 different arms, and we then can electronically steer our way through it to make sure that all the arms are either getting the leaflets going over them, unless you're in the commissure and you're able to see and figure that out, because sometimes those arms may come through it. And then to deploy the valve, since we're coming from the jugular, as you can see, there's a bit of an angle of attack that puts a little bit more tension, but making sure that we're still in the right place. And then ultimately then delivering the rest of the valve. As you can see, it is proceeding along. You've got, here we go, is the rest. Sorry, it's jumping. Go on to the next one. It looks like I lost my ability to control this. As you can see, now it's fully deployed. This is, again, all the 3D ICE images. We've got very nice 2D images showing how low profile this particular bi-leaflet valve is. If you can go on to the next slide. We then confirm with color that, well, sorry, we just confirmed with color that there wasn't any significant regurgitation. Go on to the next slide. And we also, at the end of the case, we're all done. Our surgeon allowed us to get our echocardiologist to get back in there and by TOE confirm everything we saw by the 4D ICE system. And so I had a very nice implant that we were able to inadvertently prove that we could do the entirety of it by 4D ICE and not TOE. So thank you.
So thank you very much, Scott. A very impressive case, an innovative technology. So it's a kind of single leaflet valve. Very interesting. You did all the implantation using ICE. So one question, to come back to the a little bit political topic we have heard before. Are you doing the images as an interventional cardiologist, or you have your echocardiographer helping you? And if yes, in which way? How is that organized in terms of cath lab setup and so on?
Right. So one of the nice things about the newer generation systems like the Nuvera system is it's just very stable. So as the interventionalist, I position the catheter and I can, using the independent tip rotation, scroll through the image to change the plane slightly. But then fundamentally, it's electronically steered, a lot of it. And so creating your imaging planes, creating your 3D views, and that's all done on the console can be done by our echocardiologist. We've also done cases where we have an echo technician who is doing it too, to allow the echocardiologist to go also read transthoracic images, or everybody to be just more efficient in that way.
So I agree. I think everybody is needed, and there is no discussion to take somebody out of this process. I think we need the imaging specialist as well at any time, also when we do only ICE, because at some point you will need an adjunctive imaging modality. You will need to have an adjustment of your MPR on the machine directly. So the imaging specialist definitely need to be there. So Stefan, there is some additional question.
I think we should do a rapid fire with those. So we have multiple questions now coming back from Asia and Northern Africa to Europe. And one of the first one is by Francesco from Italy. And he's asking, is the ICE probe more difficult to manage if you insert it from the left groin than from the right groin? Are there differences, like transeptal puncture? Is it difficult to steer, or can we use anteflexion and simply overcome this?
Scott.
Yeah, I think there is some slight differences when you come from the right groin versus the left groins, particularly if you're going, I know we're supposed to talk tricuspid, but when we do these for the mitral cases, particularly when we want to put it across into the left atrium, it's just a little bit easier to do it from the right groin. but you certainly can still do it from the left groin as well. And from tricuspid cases, I have not noticed any significant difference left groin versus right.
The next question is, I think, a little bit for you, Fabien, Isabelle, and Becky. At which side is the leaflet insertion? And this question comes from Stockholm, Sweden, from Andreas. At which side is the leaflet insertion at T-tier most difficult to see with 3D eyes? More anterior or more posterior? We know that the flexion is more if you use a TEER device to get really into the posterior groove, etc. So where is it more difficult to see leaflet insertion? Perhaps we start with Becky.
Yeah, no, I think it really depends a lot on the positioning of the probe. It's very, very easy to get push the probe in further to get more toward the anterior septal and then pull it back to get toward the posterior septal. We've not seen a lot of difference in that. And then remember that because you have lateral, in some probes, you have lateral flexion as well as anti-flexion. You can actually get yourselves aligned. And the nuance of the ICE probe, by the way, is that because it's a linear probe, the best imaging is still along the long axis of that probe. And therefore, we're heavily using, again, adjunctive imaging, the TEE, to guide the positioning of the ICE probe to optimize the number of elements that are firing in order to see the device arms. And so, again, we've not noticed that there's any significant difference. It all depends on whether or not you're able to get the probe positioned well over the exact site of grasping.
Very good. And we have another question from Scandinavia. And this is, do you have a good strategy in your cath lab to reduce radiation for the interventional imager doing ICE? This is also a question on TOE for most centers that may not use shields actually for their echocardiographer, which I would strongly support. We, for example, stand on the left side of the patient and find it quite hard to stand close to the left groin and also still stay protected behind the shield. So perhaps a question for Isabelle. How would you arrange the cath lab setting? Does the imager has to come on the table? Or do we need somebody to control rather the keyboard and stay more protected? So
That's
then you
a very
could
good question, because we
stay in a different place.
as imagers are sometimes in a very high center of radiation. So this is a very good point. And I think with ICE, there is the benefit that we can, first of all, if the probe is inserted, the probe can lay still, and we can basically withdraw ourselves into a center or maybe behind a shield where we can stand on the right side or maybe way far back than if we have to for TOE, because we don't have to stand directly at the patient, but we can just manage the MPR, for example, at the computer. So this might be a great benefit for ICE. So the cath lab setup could be way better than with ICE.
Absolutely. And there are a lot of remarks from Scandinavia and from Germany also by Friedrich and Charlotte that also congratulate us for this webinar, but also ask for the new role actually of the transition of the echocardiographer to the interventional part in the cath lab. And again, I think this is something for Fabien.
That's for Stefan and Isabelle. I mean, you transitioned from imaging to intervention. I will not transition anywhere. So is that something? I think that's very important. You know, obviously, if you have knowledge of imaging, you are just a better interventionalist in terms of mitral and tricuspid procedure. So what is your feeling? That's a way you would advise young people to do, or what would be your advice?
Absolutely. There are different socializations in different countries, I must say, of course. So there are some hard barriers so far between non-invasive imaging and the intervention. I was doing congenital in the past, so I transitioned totally 15 years ago, so already some time ago. But I think it's a very good way, and we actually in Mainz also engage everybody to start with echo imaging, then go to coronary and general interventions, and then come back to structural. And I think this is a very good way to not only understand the heart, to be able to scan yourself, but to also read the images while doing the intervention. It's not about deploying something anywhere, it's about precision. And I think that would be the key point, and I think you have to learn both.
Yeah. I think more and more, you know, the interventionalists will learn from the imaging, of course, as always, but also the way around, you know, the imager will be able to learn new technique and new imaging capacities and modalities from the interventionalist. Yeah. Isabelle, do you want to react?
Yeah, the one thing, I think if we are not separated by a curtain anymore, I think that would be really helpful. And the beneficial thing with ICE is that maybe the interventionalist and also the imager can be on the the same part of the patient and look each other in the eyes. That would be really great. I think it's very great potential for the future.
Maybe one last question to you, Scott and Becky. Obviously, there are also some limitations of this technique. They are not broadly used. So how do you see the future as a conclusion? What are the barriers limiting this technique to come into clinical routine? Maybe just a few words from each of you.
Yeah, I mean, I think one of the barriers is training. And toward that end, there are simulators that are developed by the ultrasound companies, but others as well, that may allow us to learn the techniques and rotations of the probe for all anatomies, for all different anatomies, since we're using it also for mitral and left-sided procedures. And that would short track the training that's required. And in addition, we're using echofluorofusion, which again allows the interventionalist to learn from the imaging and the imager to learn from the interventional fluoroscopic image, because we're both seeing the same screens, all the screens at once. So I think that all those things are going to help us.
Scott, final words?
I totally agree. I think one of the key things is going to be education, and for that, it's standardization of how we do the procedures to be guided by ICE. There's going to be little nuanced differences between one platform versus another, but that's what we need to develop next.
Excellent. Thank you very much. So we are at the end of this webinar. Thank you everybody for joining. Thank you to all the faculty for making this happen. And I think it was really a great learning for everybody. So I hope we could bring you a little bit this technology a little bit closer. We can give you some practical advice how to use it and what are the indications, and we show you finally, I think, fantastic example of this technology. So I just want to thank everybody and to close this webinar. That's the last of the year. That's the last also in this PCR studio. So we will give you a new webinar next year in a brand new studio from PCR Live from Paris. Thank you very much to everybody. Have a good evening everywhere around the world.